For more than a decade, Farxiga, dapagliflozin, has been trusted again and again and again. Now's the time to choose Farxiga for your patients. To view clinical and safety information and see what makes Farxiga different, visit farxiga-hcp.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, this is Rick Ferraro, imaging fellow at University of Michigan and previous general cardiology fellow at the Johns Hopkins Hospital. I am so excited to be bringing a case to you tonight with the incredible Dan Ambinder, co-fellow of CardioNerds. Dan, how are you tonight?
I am fantastic, Rick. Thanks for introducing me and excited to be here and learn about some great cardiology.
That's awesome. I'm excited too. And we have two incredible guest physicians tonight, Doctors Sahar Samimi and Dr. Lorraine Mascarenhas, who will be joining us from Baylor. Sahar, really nice to meet you.
Hey, CardioNerds. Hi, everyone. I'm Sahar, and like we mentioned, I'm calling in from Houston, Texas. I'm super excited to be here. A little bit about me. I love hiking, and it's absolutely my favorite way to recharge after a couple months of hard work. I actually just came back from a trip to Northern California, visiting Redwood National Park, which was phenomenal. I also enjoy trying new food and new restaurants, and Houston, as many of you may know, is a great place for that. I would recommend Roomies in Post Oak if anyone drops by. Professionally, I'm at the tail end of my internal medicine intern year here at Baylor College of Medicine. And prior to that, I completed a 2-year postdoctoral research fellowship in structural heart disease, and I'm interested in anything related to our heart valves. Super excited to be here. Thank you for having me.
And hey everyone, I am Lorraine. I am a cardiology fellow at Baylor College of Medicine in Houston, Texas. I'm originally from Chicago. I did my medical school at Toro College in New York City, and then I went on to do my internal medicine residency at the University of Minnesota in Minneapolis. In my free time, I love to be with my family, my dog, and travel.
That's incredible. It's going to be a great conversation tonight, and it's great to hear a little bit about your interests and about Houston. I've never been to Houston, but I've heard so many incredible things. I'd love to hear about one of your favorite spots, so maybe we can discuss the case.
I recently went to the rodeo. It's not quite a spot, but I will say that was an amazing time. Amazing food, a lot of fun outdoors. So it's definitely a unique experience.
All right. I think this is the first ever, and Dan can correct me, but I think this is the first ever case report from the rodeo. So this is really exciting.
Rick, heck yeah, it is. This is super exciting. All right, team, why don't we get started with your case?
Absolutely. Our patient, Miss D, is a 38-year-old woman with known history of type 2 diabetes and hypertension, well controlled on oral medication. She has a history of stage 4 endometrial cancer diagnosed about 6 months ago, for which she's on chemotherapy consisting of carboplatin and paclitaxel. She also has a history of prior PE from around the same time, for which she is being treated with apixaban, and she is compliant with her apixaban. She is presenting with acute onset left upper quadrant abdominal pain, chest pain, and shortness of breath from 3 days ago. A little bit more about her present illness. The pain in her abdomen started suddenly from 3 days ago. She describes it as a deep pressure-like sensation in the left upper quadrant radiating to her left flank. The pain has been consistent since it started and is not associated with eating, nausea, or vomiting. She denies dysuria, urinary frequency, diarrhea, or hematochezia. She also endorses pleuritic, sharp chest pain, and also reports subjective fevers and chills intermittently from about 2 weeks ago, along with a general feeling of malaise. Now, Lorraine, given her advanced cancer diagnosis and current symptoms, I was immediately worried about another PE or thromboembolic event. But arguably, she's on apixaban that she is compliant with. Of course, other differential diagnoses on the table that we do not want to miss include acute coronary syndrome, given her traditional risk factors of diabetes and hypertension, an aortic dissection, given her hypertension, although both were well controlled, To add to that, pericarditis and myocarditis are important differential diagnoses given the symptoms, history of malignancy, and chemotherapy use. What do you think, Lorraine?
Absolutely. Whenever we see a patient with active malignancy and a history of thromboembolism presenting with new pleuritic chest pain, PE is high on the differential. We also have to consider other causes of her acute chest pain, as you mentioned, Sahar, like ACS, pericarditis, myocarditis, and aortic dissection. However, her left upper quadrant and flank pain raised suspicion for additional pathologies. Sahar, can you share your physical exam findings with us?
So, on physical exam, she had a low grade fever of 100.2. Her heart rate was regular 92 beats per minute. She had a stable blood pressure of 125 over 70 millimeters mercury. Her respiratory rate was 20 breaths per minute, and she was satting 96% on room air. She appeared fatigued, but not in severe respiratory distress. She had no peripheral edema. Lungs were clear to auscultation bilaterally. She had left upper quadrant tenderness or deep palpation and mild flank tenderness. We could hear a new grade 3 diastolic murmur, best heard at the right upper sternal border. And notably, we noticed splinter hemorrhages on a few nails evident bilaterally. So, as a reminder, what are splinter hemorrhages? A splinter hemorrhage is a small linear area of bleeding under the fingernails or toenails. It appears as a thin reddish brown line that runs parallel to the nail growth. Of note, she did not have related physical exam findings of Janeway lesions or Osler nodes. Janeway lesions are small, flat, painless red or reddish blue spots or patches that appear on the palms and soles. And Osler nodes are painful red raised lesions typically found on the pads of the fingers and toes. These two are classically signs of infective endocarditis.
At this point, given these findings, especially the new diastolic murmur and the splinter hemorrhages on exam, we were very concerned about endocarditis. Her advanced malignancy and prior PE conferred a hypercoagulable state, but we're also considering infective endocarditis here, given she's immunocompromised in the setting of her malignancy and active chemotherapy treatment. So, our main differential at this point, given the symptoms, was infectious versus non infectious endocarditis complicated by emboli. So, we needed a comprehensive workup to clarify what's driving her presentation, and further imaging was incredibly useful here. So, moving on to the next steps in her diagnostic evaluation, her labs were notable for a slight leukocytosis at 11.2. Her hemoglobin was 10.5, so mild anemia, but this is at her baseline. Platelets were 220, and her basic metabolic panel was largely unremarkable. She had normal renal function with a creatinine of zero point 0.8. Her coagulation studies showed an INR of 1.2, and as mentioned previously, she's on apixaban at home. And blood cultures were obtained, after which she was started on broad spectrum antibiotics with vancomycin and cefepime for empiric infective endocarditis treatment. A chest x ray was obtained and showed no acute infiltrates, overt consolidation, or gross pleural effusion, and she had a normal cardiac silhouette. Given her flank and left upper quadrant pain, a CAT scan of the abdomen and pelvis was performed, and it showed new peripheral wedge shaped hypodensities in the spleen and kidneys concerning for splenic and renal infarcts. She also had complex bilateral adrenal masses that were most compatible with neoplasm. A CTPE was also done to rule out recurrent PE, and unfortunately, it showed new subsegmental PEs in the right lower lobe compared to a prior CT 6 months ago. Because of the new diastolic murmur and the possibility of endocarditis, a transthoracic and ultimately transesophageal echocardiogram were obtained. Sahar, can you tell us about those echo findings?
The transthoracic echocardiogram that was done while hospitalized showed a normal left ventricular ejection fraction of 60%, an elevated right ventricular systolic pressure of 55 to 60 millimeters mercury, and a dilated right ventricle. It also demonstrated severe aortic regurgitation with thickened aortic valve leaflets, but no obvious vegetations or other valvular abnormalities. A transesophageal echocardiogram was done for better visualization of the aortic valve. The TE ultimately confirmed severe aortic regurgitation. It also demonstrated thickened aortic valve leaflets and suspicious small lesions along all three commissural lines, which were best seen in the 3D view. Again, no large vegetations were seen. The patient was empirically treated with broad spectrum antibiotics given ongoing concern for infective endocarditis. However, her blood cultures remained negative throughout the entire hospitalization. So our differential at that point was culture negative endocarditis versus non-bacterial thrombotic endocarditis.
So let's talk about NBTE, or non-bacterial thrombotic endocarditis. In a patient with advanced malignancy, recurrent embolic events, valvular lesions on echo, and negative blood cultures, NBTE should be high on the differential.
NBTE, also called merantic endocarditis, involves sterile vegetations comprised of platelets and fibrin that form on valve leaflets. While it is unclear how these vegetations form, potential mechanisms include endothelial injury, inflammation, hypercoagulability, and immune complex deposition. Malignancy is the leading cause of NBTE, and it should be excluded in cases without a clear etiology. Other common causes include autoimmune pathology such as lupus and antiphospholipid syndrome. If there are no obvious triggers and MBT is found without a known malignancy or autoimmune disorder, they should be investigated thoroughly for an occult cause. Regarding clinical presentation, most patients present with sequelae of systemic embolization. For example, in the case of our patient, she presented with left upper quadrant pain and was found to have splenic and renal infarcts.
This diagnosis requires a high degree of clinical suspicion. The go to imaging modalities here are the same for infective endocarditis, being transthoracic echocardiogram, as well as transesophageal echocardiogram if equivocal or for further assessment. The sterile thrombotic vegetations in NBTE may manifest as either one, small, less than 1 centimeter, broad based hyperechoic verrucoid nodules, usually at the valve commissure or on the low pressure side of the leaflets, or two, as diffuse valvular thickening. On imaging, NBTE more commonly involves the mitral and aortic valves compared to the right sided valves. Importantly, in order to diagnose NBTE, infective etiologies such as culture negative endocarditis need to be ruled out, which can be very difficult. Culture negative endocarditis is defined when 3 or more sets of blood cultures collected over 48 hours remain negative despite a prolonged incubation time, and this usually means over 1 week. It's commonly associated with fastidious organisms such as the Hayseck group of organisms like Haemophilus, Eikenella, Kingella, as well as intracellular organisms that can't be cultured using traditional techniques like Coxiella burnetii and Bartonella. Reassuringly, for the fastidious organisms, modern automated blood culture systems have made detection easier, and for the intracellular organisms, serologic tests can be considered. For both groups of organisms, PCR of the blood or explanted valve tissue can be considered in select cases. As mentioned, our patient was empirically treated with broad spectrum antibiotics despite negative blood cultures, given our suspicion for culture negative endocarditis. Furthermore, we sent specific cultures and serologies to test for these fastidious and intracellular organisms described with the help of our infectious disease colleagues. After infection was ruled out, our patient was ultimately diagnosed with NBTE. Sahar, how are these patients managed?
So management includes multiple pillars, the first one being anticoagulation. So patients with NBTE should be treated with anticoagulation, and the choice of anticoagulation depends on the underlying etiology. There are no clear recommendations for the management of NBTE in either the 2020 ACC/AHA guideline for valvular heart disease or the 2023 ESC guideline for the management of endocarditis. Our patient was already on apixaban for a history of PE, but had breakthrough embolic events, so she was switched to low molecular weight heparin. In the case of cancer-related thrombosis, when compared to vitamin K antagonists, low molecular weight heparin has been associated with a reduced risk of recurrent venous thromboemboli. So it has historically been the go-to agent of choice in these patients. However, this has shifted over the last decade since the emergence of DOACs. While RCTs and observational studies have demonstrated equivalent efficacy of DOACs to low molecular weight heparin, they are associated with an increased bleeding risk. So the specific choice of agent depends on shared decision making and a risk benefit discussion. As a side note, for patients with NBTE due to antiphospholipid syndrome, warfarin is the preferred anticoagulant. The second pillar is managing the underlying causes. In our patient's case, this revolves around aggressive oncologic management. She has been working with the amazing oncology team at MD Anderson who adjusted our chemotherapy regimen to better control her endometrial cancer. Third, valvular surveillance. Serial monitoring of valve involvement and functioning can help determine treatment efficacy and duration. In the case of our patient, her severe AR was concerning given the potential to cause heart failure if left untreated. Reassuringly, with appropriate treatment, her follow-up TTE 2 months post-discharge showed decrease in AR severity from severe to mild to moderate. If this wasn't the case, in NBTE patients, intervention may be needed if the valve dysfunction is hemodynamically significant and or progressive. Lastly, multidisciplinary collaboration. Cardiology, oncology, and sometimes even cardiothoracic surgery, if surgical intervention is on the table, are needed to collaborate for patients with NBT. So, to summarize, we want to emphasize 5 clinical pearls regarding non-bacterial thrombotic endocarditis. First, eliminate the usual suspect. NBTE is a diagnosis of exclusion. Always rule out infective endocarditis first with serial blood cultures and serologic tests. 2, there's more than meets the echo. Distinguishing NBTE from culture negative endocarditis can be tricky. Look beyond the echo, focus on clinical context, including underlying malignancy or autoimmune issues, and lab findings to clinch the diagnosis. 3, TEE is our choice, mostly. While TEE is more sensitive than TTE, non-bacterial thrombotic endocarditis vegetations can be sneaky and may embolize quickly. Don't hesitate to use advanced imaging, including cardiac MRI or repeat imaging if you still suspect non-bacterial thrombotic endocarditis. Choose your champion. In cancer-associated non-bacterial thrombotic endocarditis, guideline recommendations for anticoagulation choice is lacking. Consider DOACs and low molecular weight heparin as agents of choice, but ultimately use shared decision-making to guide management. No obvious trigger? Go hunting for hidden malignancies and autoimmune disorders. A thorough workup is essential to uncover the driving force behind NBTE.
Wow, what an incredible case that you brought here. And I'm going to be honest, I was just kind of sitting and listening and thinking about, should I jump in and say this or that? And honestly, you covered all the bases. It really, you put a lot of thought into a tough case. And as you mentioned, non-bacterial endocarditis is really, really tough. This is one of the toughest things we run into as internal medicine physicians, as cardiologists, as imagers, as diagnosticians. It's really, really challenging. And the way that you covered all your bases and really evaluated as thoroughly as you did is commendable. This is incredible. A couple additional things I just wanted to mention, and then I would point our readers to. There was actually a really recent, earlier this month, this is May 2025, scientific statement in the Journal of the American Heart Association on culture negative endocarditis. And it's a really helpful document because it's, as you had mentioned, it's related to a lot of what you said. It's NBTE is a diagnosis of exclusion, and culture negative endocarditis is extremely challenging. You all went through a lot of the pertinent points, so I'm going to leave that to you all, but that's definitely a great document and one to help guide practitioners across fields, I think, and one definitely to keep in your back pocket. One other thing I wanted to mention is utilizing modalities. And so you had talked about TEE, which is really in the setting of endocarditis is really our workhorse. TEE is what we use to evaluate the valves in the heart in general in the setting of endocarditis, assuming that there aren't other contraindications. But I wanted to touch on really briefly, what are some other things that we can do Cardiac CT is also really helpful. And you had mentioned the ESC guidelines. The 2023 ESC guidelines actually give cardiac CTA a class 1 designation for native valve endocarditis to detect valvular lesions and confirm the diagnosis of infective endocarditis. Another great tool in our armamentarium is PET-CT. As an imager, and it's one that does a lot of nuclear medicine. I spend a lot of time with PET-CT. This is particularly helpful in the setting of prosthetic valve endocarditis. It's not very sensitive. It is specific, but not sensitive in native valve endocarditis. And so I don't think this specific case would be the best for it, but can be very helpful with diagnostic challenges if you're thinking about prosthetic valves or a device infection as well. And so overall, this is an incredible case. We could talk about this, a lot longer, but I really want to commend you on a great case, and thank you for sharing with us.
Thank you so much for having us.
Guys, that was absolutely terrific. And this is definitely one of the best rodeos I've ever been to.
And now for our faculty presenter, Dr. Basant Arya. He is a cardiologist with us at Baylor College of Medicine. He has been in practice for more than 15 years. He's an excellent clinician, cardiologist, and educator, and has been awarded for his role as an educator. And I've had the pleasure of working alongside him and Sahar, and we're really happy to have him here today.
Thank you, Lorraine. And thank you, Sahar. Both of you did a great job with presenting the case. I am Dr. Arya. I work here at Baylor St. Luke's Medical Center here in Houston. I'm a non-invasive cardiologist focusing mainly on echo and nuclear cardiology. So our case was an interesting case who came in essentially for what sounded like multiple infarcts in her spleen and also new pulmonary embolism. And so we were initially working her up for infective endocarditis. And as both Sahar and Lorraine have alluded to so far, all of the infectious workup was negative. This unfortunate young lady also had malignancy, quite advanced. And so we started to consider the possibility of non-bacterial thrombotic endocarditis, which often is seen in advanced malignancies, especially adenocarcinomas, and more so in pancreatic adenocarcinomas, but can also be seen in hypercoagulable states associated with systemic lupus erythematosus, antiphospholipid syndrome, and other hypercoagulable states. So what's different from bacterial endocarditis versus non-bacterial thrombotic endocarditis is that these lesions that you see on the valves are essentially sterile platelet thrombi on the heart valves. And they often are seen on the aortic and mitral valve, mitral more than aortic. And the reason why they happen is because of endothelial injury in the setting of hypercoagulable states. And often, as in advanced malignancies, circulating cytokines such as tumor necrosis factor and interleukin-1 often will set up the stage for endothelial injury on the valve, and then the hypercoagulable state causes these platelet thrombi to be formed. So the vegetations that we see in non-bacterial thrombotic endocarditis is essentially platelet and fibrin and immune complexes, and is often referred to as white thrombus. So these often have some characteristic features, and so as you look through the case, I would draw your attention to the echo images that we are showing. And the initial transthoracic images are shown, which the aortic valve looks trileaflet, doesn't seem particularly diseased as such when you look at the initial 2D images. But when you put color on it, you realize that there's significant aortic regurgitation. Now, this is in the setting of no dilation of the aortic root or ascending aorta. And so that should prompt you to think of, possibility of vegetations on the valve, which are, smaller than the resolution of a transthoracic echo. Now, this lady had, multiple infarcts in her spleen. She had also, pulmonary embolism. So we felt that despite her being immunocompromised and her counts being a little bit on the lower side, that a TE was justified to look into things further. And so I draw your attention to look at the TE images, and there you can see that on the 3D reconstruction of the valve, you can see that the valve leaflet itself looks pretty thin, but at the commissure, so right where the three leaflets meet in the middle, you can see that there's thickening of the valve, and there is vegetations which are pretty small, less than a centimeter for sure. They're more like a few millimeters in size, and they look like they have what we call a stuck-on appearance on the valve. They don't necessarily seem like they are destroying the valve in any particular way. And then on the color images, you can see that there's actually significant aortic regurgitation right through the middle of the valve, right where the commissures come together. So these echo findings highlight several important features of non-bacterial thrombotic vegetations versus infective endocarditis. So in infective endocarditis, often the lesions are large and very mobile, while here the lesions are small and also non-mobile. Infective endocarditis can often have a tendency to destroy the valve. And so in infective endocarditis, you can see perforation of the valve, you can see extension of the infection into the aortic root. So you can see like a root abscess, which can then later on cause other issues, including conductive tissue disease. And you can see valvular regurgitation in both of these conditions. So in this particular case, the finding of these very small lesions which are attached to the leaflets, but right at the commissure, without true destruction of the leaflets, certainly made us think about non-bacterial thrombotic endocarditis. Now, as both Sahar and Lorraine had alluded to already, this is a diagnosis of exclusion. At the time when we saw her, she was having all of these things. We basically treated her like infective endocarditis, so she was on IV antibiotics, and then we did our initial blood cultures were negative. We sent blood cultures for the Hayes-Sack organisms, and also sent other testing to rule out other diseases like Coxiella and Legionella. And so you often will have to do PCR for all of these things to make sure that you don't have any of those atypical organisms there. Now, of course, she's a patient who has malignancy and is significantly immunocompromised, so any of these could certainly be happening in her case. But anyway, all of those were negative, and so essentially, in the end, her diagnosis was non-bacterial thrombotic endocarditis. In terms of treatment, given that these are platelet aggregation and really more associated in this particular case with the hypercoagulable state of malignancy, the mainstay of treatment usually is anticoagulation. Now, this particular patient had a PEs a few months prior, and she was already on Eliquis. And so this second set of issues that occurred in terms of a new pulmonary embolism as well as the splenic infarct now was while she was on Eliquis and she was compliant with the therapy. So this really is more like an Eliquis failure, which is not uncommon in non-bacterial thrombotic endocarditis, because the nature of the pathology is such that the DOACs don't work as well in these patients. So the mainstay of treatment typically would be either unfractionated IV heparin or Lovenox therapy for these patients. So she was actually a patient of MD Anderson, which is next door to us. And so we consulted with her hematologist there, and we were asked to essentially start her on Lovenox, which we did, 1 milligram per kg BID. And after a couple of days of staying with us, she moved to MD Anderson. As a follow-up, she continued with her Lovenox therapy, and the plan is essentially to continue it indefinitely. She was last seen in clinic about a couple of weeks ago by one of the cardiologists there, and she is continuing with her Lovenox therapy. Now, 2 months after her initial echocardiogram with us, which showed, moderate to severe aortic regurgitation, a repeat echocardiogram at MD Anderson showed that there have been significant decrease in the amount of aortic regurgitation, and they called it mild to moderate on their echocardiogram. So again, in this particular condition, rather than antibiotics, the treatment is really doing anticoagulation, and over a period of time, the anticoagulation would help to essentially get rid of these thrombi and decrease the amount of valvular regurgitation. And in general, valvular regurgitation is more common here than stenosis, although that can also happen. And like I said, typically the aortic and mitral valves are involved, with mitral way more than aortic valve in terms of the involvement. So I think for us, this was an interesting case where we initially started off thinking that it was a cardiac source of embolus with infective endocarditis. But as the case progressed and as we got further investigation into it, and especially with the TE images of the aortic valve, we felt very compelled that this could be non-bacterial thrombotic endocarditis. So again, I want to thank Lorraine and Sahar for the presentations, and Daniel and Amit for giving us the opportunity to showcase our case here on CardioNerds. Thank you very much.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Bhavya Shah. I'm an intern in the CardioNerds Academy House, Eindhoven, and a fourth-year medical student at Rowan Virtue School of Osteopathic Medicine. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.